Hi, I'm Bill Rapisi, Executive Director of Lymphatic Education and Research Network, and I just want to take this opportunity to thank all of you for joining us today for our symposium series. I also want to take this opportunity to thank all of you who have become members of LE&RN and help support this series so that we can continue bringing this kind of groundbreaking information to you in your homes and offices. I would also suggest for all of you who have not become members of LE&RN, $5 a month, you can become a member of LE&RN and help support this programming and the research that we do. Thanks very much for joining us, and I look forward to having you become a member.
Good morning, good afternoon, good evening to all of you. I'm going to tell you about the work that I'm doing on the genetic basis of primary lymphedema. This is our program of research very much here at St George's in London. And I hope that to explain to you what we're doing and how we're adopting a different approach to the diagnosis in particular of lymphedema, and hopefully in the future how it might guide treatment. I better just leave this slide up for a few seconds for you to just read the important disclaimer, and then we can move on. So I'm going to talk a little bit. I'm going to go back to basics and talk about lymphedema to start with, and then I'll go into the more admittedly technical areas of the primary lymphedema and the genetic aspects of lymphedema. So let's just start by talking a little bit about lymphedema. Now, if you mention, and the book has taught me this, that if you mention lymphedema to anyone, certainly in the UK, they'll say, isn't that what you get after cancer? And the answer it is. But what many people do not realise is that breast cancer-related lymphedema, which hopefully you can see on the screen, is actually only 1/8 of all forms of lymphedema. So cancer-related lymphedema probably makes up about 1/4, and breast cancer-related lymphedema makes up about half of that. So there are a lot of other causes of lymphedema. Mention the word Elephantiasis, which is also known around the world. And when I've asked about elephantiasis, I've usually got the answer, isn't that what the elephant man had? Well, the answer is strictly no, although just to qualify that, Proteus syndrome, which the elephant man did have, also has a lymphatic element to it. But that apart, elephantiasis is actually the grotesque swollen leg that you might see in tropical countries, particularly India. And again, this is what's shown on the screen here. You see a man who Gemma filmed and took photographs of using Apple technology and remote Apple photography to show a man with a leg that looks like an elephant's leg, and that's where the word elephantiasis comes from. But remember, elephantiasis is simply lymphedema, and it happens to be a name used in tropical areas where the cause is usually filariasis, and that means an infection born from a mosquito bite, which creates larvae growing in the lymph system, and the worms that then develop block the lymph system to give you filarial lymphedema, otherwise known as filarial elephantiasis. So that is what lymphedema can look like. What is lymphedema? Well, lymphedema is effectively a failure of the lymphatic system. So briefly, what is the lymphatic system? Well, it's a network of drainage tubes connected to lymph glands that essentially cleanse the body of waste, surplus fluid. So it has a role to cleanse the body's tissues. It has a role to recycle surplus fluid and cells, and it has a particular role to make sure that it guards against infection. Because as you and I well know, if you get a sore throat, the lymph glands can come up fighting against infection. So it has a very important role in defense of body's tissues. Now, what's not even taught properly in medical school is the fact that the blood circulation supplies the body's tissues with what they need in terms of fluid, nutrients, and oxygen. But actually then the tissues, when they finish doing what they want to do, the cells will throw out waste, and we need to recycle everything so that the lymph system is the cleansing system of the body. When it goes wrong, what happens? Well, it means that waste materials, cells, fluid, all build up in the tissue to give visible swelling. It also means there's a problem locally with infection, and the combination of swelling and horrendous infections at times is what lymphedema is all about. Now, I'm sorry if this slide on the left offends you. I just want to make the point that there are many different forms of lymphedema. It can affect a leg, a face, a breast, an arm, the genitalia, the body, anywhere. And there are many different causes. I've mentioned breast cancer-related lymphedema, and I've mentioned filariasis. But actually, in Western society these days, the epidemic is as much to do with immobility, because moving is an important way of getting the lymph system to work, and obesity. And obesity not only impairs lymph drainage, but lymph drainage can then also lead to increased deposition of body fat. So in this slide, and if I can find the cursor, I don't know whether you can see it, but there's lymphedema in both legs, but there is also considerable lymphedema in this abdomen. So much of this swelling is lymphedema, making the person look even fatter than they actually are. If we turn to the picture on the right-hand side, we see a different form of lymphedema. And this is another tropical form of lymphedema called podoconiosis. This arises where people, particularly in Ethiopia, walk barefoot, and particular silicate particles from the earth get in through the skin and damage the lymph system. And this picture on the right is courtesy of Paul Matz and Claire Fuller, two who are working tirelessly in Ethiopia to try and improve the lot of these sufferers of podoconiosis. So why then do not all fat people get lymphedema? Why do all cancer patients not get lymphedema? And why do not all patients who walk barefoot get lymphedema? Well, the answer is probably in the genes, and a genetic predisposition or genetic susceptibility could well be the explanation for why some people get secondary lymphedema and others don't. So I've used the word secondary lymphedema there. So what is secondary lymphedema? Well, it simply means that it's a lymphedema where there is a recognizable cause. So, such as cancer treatment, filariasis, podoconiosis. But there is also primary lymphedema, and that's really what I'm going to be talking about today. And primary lymphedema is where there is an inherent or innate or genetic problem with the lymph system, so it doesn't work properly. Either there's a fault in the way that the lymph vessels have formed, so their structure is abnormal, or there's a problem with the way the lymph vessels don't work, so there'll be a functional problem. Here you see on the slide before you a young girl with primary lymphedema due to a genetic fault, and that gene has now been recognized. That gene is important for the development of the lymphatic system, and because it is not working very well in this young girl, it's giving rise to lymphedema everywhere. Her eyes are affected with lymphedema, her face is affected by lymphedema, her arms, her legs, her feet, and also the internal organs. So she has a problem with her gut and absorbing food properly because the lymph vessels of her gut do not work properly. So the studying the genes in these forms of primary lymphedema, they're going to be very important to help us understand what makes the lymph system work, and when it goes wrong, what can we do to put it right. So, as I've said, primary lymphedema is an intrinsic fault in terms of a failure of the lymph system to work properly, and it gives rise to chronic edema, lymphedema, due to that developmental abnormality. Now, how that manifests will often depend on the gene involved. So the phenotype, which is the physical characteristics of that person who has the gene fault, will vary according to the tissues affected, the time of onset, how it's inherited or not, if there are any other associated features, and so on. Now, primary lymphedema, if you go and see a doctor and they say you've got primary lymphedema, at best, all they will have done is to say, well, it came on at birth, you've got congenital lymphedema, end of story. Or many types of primary lymphedema will come on at puberty or sometimes soon after puberty, and that's been called lymphedema precox. And then other cases that may come on later in life have been called lymphedema tarda. But that doesn't help us understand the differences between the different forms of lymphedema in terms of the mechanism or the gene fault. So we've tried to look into this in more detail. And so we've introduced phenotyping, which means looking very carefully at all the associated features with the lymphedema to try and be more specific with that diagnosis. And that actually has enabled us and others to find certain genes that are then at fault and responsible for producing that form of primary lymphedema, and that's called a genotype. So when we just categorize the patients according to phenotype, it's according to how they look and the investigations. If, though, we found the gene fault, we can actually look and detect that gene fault, and that will give us a specific diagnosis, and that's what's called the genotype. Here are some examples. Now, if we go to the picture of the slide, you'll see that there are 4 pictures of primary lymphedema. And in not so very long ago, they would have just been diagnosed as congenital primary lymphedema. But in fact, we now know that there are 4 different genes causing these forms of primary lymphedema. And without wishing to get too complicated, the one in the top left-hand corner is true Milroy's disease that you may have heard of due to this mutation in a particular gene called VEGFR3. If we go down to the, I'm trying to use the cursor but can't quite find it. If we go down to the bottom right-hand corner, then actually a growth factor that stimulates that receptor, that's where the mutation is. And so they produce a very similar form of Milroy type lymphedema, but the gene is actually different. If we go to the top right-hand corner, this is a different gene altogether, but we now know that that gene is also responsible for affecting brain size and also for affecting eyesight. So identifying a gene also tells you a lot about other possible abnormalities that can occur with the lymphedema, and also a bit about the natural history and the prognosis of their condition. And in the bottom left-hand corner, we have Turner syndrome. Now, to be fair, we don't know the mutation yet, but we know it is on a chromosome, one of the female chromosomes, and or rather on one of the female chromosomes, so it's only females can get that form of lymphedema. But here's an example where not so long ago this would have just been called congenital lymphedema, and now we have genes identified that can enable us to make a specific diagnosis. Now, if we go to the full screen and the slide here, this will make you panic, but it's not meant to, because this is how we approach our patients when they walk into the clinic. And I'm going to use the rest of the time for the symposium of walking you through this chart, this algorithm that we use to try and understand what form of primary lymphedema our patient has. So we start at the top with what we call syndromic. We then move one down to what's called systemic or visceral, which means is there any internal body involvement with the lymphedema? And then we'll go on to issues of disturbed growth, and then we might end up with congenital or late onset. So let's look at the syndromic. And what by syndrome we mean, has this patient before us got a recognized syndrome like Down syndrome, or like Turner syndrome, or like Noonan syndrome? And that means that the lymphedema is not the dominant element in the diagnosis, but it's nevertheless an important aspect of it. So if we look at Turner, first of all, Turner syndrome, as I said, is a fault on one of the female chromosomes, and it results in a very high level of miscarriage during pregnancy. Furthermore, many of the babies that are born are very swollen with fluid, and of course it's no surprise that much of that fluid is because lymphatic development is faulty, and they therefore cannot manage to drain fluid or process it properly. Turner syndrome patients are female, and they can have hand swelling, foot swelling, and they also struggle with infections. And in the picture here, the particular infection is wart virus infection, but they can also get bacterial infections and fungal infections like any lymphedema patient. So diagnosis relies on looking at the chromosomes. It's not particularly an inherited disorder, but may occur rarely more than once in a family. And the mechanism appears to be a failure of the smallest lymph vessels to work properly. So we've moved from the blue syndromic box. We've now said, okay, that there is no recognizable syndrome. What do we do? Well, we then move to the next box, which asks the question, is there any internal involvement with lymphedema? In other words, a fault of drainage of fluid from the lungs, from the gut, from the heart, wherever it happens to be. And this has been a source of great interest recently because a number of new genes have been found to cause what we call a generalized lymphatic dysplasia. So the lymph fault is widespread throughout the body. And I'm going to just use one example here of a mutation called PISO1 that causes widespread fault in lymphatic development. It also produces this hydrops, which is widespread fluid of the fetus of the newborn, and it causes particular problems such as facial swelling and facial infection, what we call cellulitis. And that, if we see that in a child, we think of this mutation. And hydrops is quite a common problem, And we're beginning to realize that non-immune hydrops, so it's not to do with any blood incompatibility, for example, the non-immune hydrops, many of these patients will actually have a fault in their lymphatic development. And therefore, it's probably that failure in lymphatic development that's giving rise to so much fluid. And as it says on the slide, it can be frequently associated with a number of conditions. Noonan syndrome, Turner syndrome, Henicam, which was actually what the child in the black and white photographs had, and of course PISO-1. So hydrops is begin to realise that an indicator there might be a more widespread problem. So we've done the syndromic blue box. We've now said no to that. We have now asked the question, is there any internal involvement as far as lymphatic problems are concerned? And we've said no. So we then ask the next question, is there any disturbed growth or birthmarks associated with this lymphedema? Now this box is slightly different from all the other boxes in that the genetic fault is usually confined to the tissue affected rather than being in the blood and therefore possibly inherited. So this problem usually arises after birth, where one cell type in a tissue starts to mutate, and therefore the mutation can affect different tissues like fat, skin, muscle, and cause overgrowth. And this has been a source of great interest, this area of overgrowth, and I'll show you in the next slide why. This is a pathway, a cell signaling pathway called the mTOR pathway that has been very, very interesting for cancer biologists, because this pathway makes cells turn over very quickly. They reproduce very, very quickly. And if that happens very, very quickly, then it can be involved with cancer development. But it can also, if it doesn't cause cancer, can also cause cells purely just to grow more than they should do, not in a malignant way, purely to get overgrowth. And there are a number of conditions, many of which are associated with lymphedema, that can do this. And the important thing about this pathway and finding a gene fault associated with lymphedema in this pathway is we have drugs that can actually normalize the signaling in this pathway and therefore treat elements that have gone wrong, like overgrowth and like lymphedema. So this rather a bit of a mouthful of PIK3CA is right at the head of that pathway, is the gene involved, and it causes very characteristic overgrowth, often associated with lymphedema. And if I can just use one, if I've got now, there we are, there's the pointer. This KTS is known as Klippel-Trenaunay syndrome, and it leads to lymphedema, varicose veins, vascular birthmarks, and overgrowth. So this young girl has been diagnosed with Klippel-Trenaunay syndrome, and she, as you can see here, has actually birthmarks in the skin, and there is quite obvious lymphedema, particularly in the lower leg, feet and ankles. But on the back of her leg, a lot of those birthmarks are actually malformations of lymph vessels, not blood vessels, but lymph vessels. And it is lymph that tends to leak out of those abnormal vessels. But she's also got lymphedema because the malformation, the malformed lymph vessels connect with the main lymph drainage routes to give rise to the lymphedema. So that's a lymphatic malformation. Here we have another lymphatic malformation, in other words, a gene fault which we don't know, confined to the tissue, has caused malformation of lymph vessels, but they are not connected with the main lymph drainage pathway. So there's no lymphedema. The swelling is due to lymph fluid being trapped in the little lymph vessels and bigger lymph vessels of the thigh to cause swelling, but it's fluid, it's lymph fluid that's actually trapped within these malformed lymph vessels, whereas the normal lymph drainage pathways means that the lower leg is fine. And because the lymph doesn't know where to go, it will often bulge on the skin surface as little lymph blisters. So these forms of lymphatic malformation are referred to as mosaic disorders, which means the mutation is confined to the tissue. It's not inherited, it's not in the blood, but if we take a tissue sample from this site, we hopefully in due course will learn more about the mutations causing these sorts of lymphatic malformations. So we've now decided there's no syndrome with involved with lymphedema. There's no internal involvement of abnormal lymph vessels, and there is no overgrowth. So when we've done that, we've just got plain simple lymphedema. We might then say, well, has it come on at birth or has it come on sometime later in life? And so I'm now going to look at one form of congenital lymphedema that many of you may have heard of, called Milroy Disease. This was the first primary lymphedema for which the gene was identified, the VEGFR3 gene. And it's not that common. And in fact, many patients with congenital lymphedema are often told they have Milroy disease, but unless the genotype, in other words, the gene mutation, is identified, that person strictly hasn't got Milroy disease. So what is Milroy disease or Milroy lymphedema? Well, as I say, it's due to a mutation in this vascular endothelial growth factor receptor 3. Sorry, bit of a mouthful that. But what it's taught us, we've started to learn what other factors can be produced by these gene faults, what other conditions. So in these patients, not only do they have lymphedema of their toes, their feet, their ankles and their legs up to their knees, but they also have abnormal veins, and they also can have lymph fluid around the testicle in the male. About a third of male infants born with this will have hydrocele. So that's effectively lymphedema of the testicle. And when we study these patients who have a known gene fault, we start to understand more about how that gene fault affects the lymph system, what goes wrong, where the fault is. And in Milroy disease, it's due to the fact, like in Turner, the small lymph vessels don't work properly. So if we look here, on the left is a normal lymph scan where we have injection of dye into each foot. So the right foot is there, and the dye travels up the leg to the knee area and then on to the groin where the lymph glands sit. And we can see pretty well there are good lymph vessels working normally, and there's good uptake of dye as a surrogate for lymph in the lymph glands. In the Milroy patient with the gene fault, we don't see anything. That's not because the lymph system isn't there. It is there. We've shown that. But the problem is that the small lymph vessels, the little small lymph vessels, are just not absorbing material and fluid from the tissue. So nothing gets into the lymph system. And I believe that, and in the bottom right-hand corner, you can see little lymph vessels in the skin, which are there in Milroy disease, they just don't work. And if through more research we can unlock the key that's failing to get these little lymph vessels to work, we can cure this condition. And I feel confident that can be achieved. So Milroy disease is inherited. It's not mosaic like the malformations and the overgrowth. It is inherited. You can inherit a mutation, but not necessarily develop the disease. So the mutation may not express itself in lymphedema if one's lucky. Furthermore, a parent may be so mildly affected they don't even know they've got the disease, and you don't have to inherit it. As an individual, one can develop this for the first time. And as I've said, the mechanism appears to be the little lymph vessels. They're there, but they just don't work. So we're now moved from the congenital to the last box, which is called late onset. We don't distinguish anymore between puberty onset and tarder, later onset in life. And the reason for this is this condition, lymphedema distichiasis, due to a mutation in the gene called FOXY2. I won't elaborate on that. When I lectured once and said this was FOXY2, the audience misunderstood me because they thought I was being foxy, but no, the gene is actually called FOXY2. One of the problems with these symposia is you don't get the laugh back from the audience, so you can't quite appreciate where anyone's got the joke or not. So lymphedema distichiasis is due to this mutation in FOXY2. Distichiasis means a double row of eyelashes. You might say, well, what's that got to do with lymphedema? Well, nothing directly. It's just that this gene makes this eyelash phenomenon, which should result in a follicle, an eyelash follicle changing into a grease gland. That doesn't happen, and the lymph vessels don't develop at the very specific time that the embryo is growing. So what happens, this is a syndrome, but the lymphedema is the dominant feature, and unlike Turner's syndrome, for example. So we get lymphedema onset at puberty usually, but we know that the lymphedema can come on many years after that. So this proves to us that although we've got one gene fault, in one person the lymphedema may come on at puberty, but in the next person in that family it may not develop until that person's 40 or 50 years old. Again, we have a strong link with varicose veins and other abnormalities such as cleft palate. So this is a syndrome, a constellation of associated features caused by this one gene. And again, the lymphoscintigraphy, you've got the picture on the left, which is the normal that I showed you before. And on the right, we have yet another abnormal appearance. And this is because the dye is being taken up by the lymph system. So those little lymph vessels that weren't working in Milroy are working very well here. But what happens is that the lymph or the dye gets so far up the legs and then gravity makes it fall back down again. Why is that? Because the main fault here is the lymphatic valve. The lymphatic valve is very important for ensuring that lymph flows in one direction and can actually flow up against gravity. And that fails in this condition, so all the lymph just falls back down again. So here, the research work needs to concentrate on the lymphatic valve if we're going to find a cure here. So this condition is also inherited. Interestingly, the double row of eyelashes occurs at birth, but the lymphedema doesn't appear until puberty. Interesting, we haven't explained that. And again, the mutation may be carried but not expressed, and the mechanism is because of a lymph valve failure giving rise to reflux of the lymph fluid. Now, one final gene fault, again we have it in this late onset primary lymphedema fault, and this gene is called GATA2. And why I'm mentioning this one is because this is a combination, this gene fault gives rise to blood abnormalities, and to immunodeficiency. That means this gene not only gives rise to lymphedema, but means that the bone marrow is affected, so the blood and particularly the cells responsible for fighting infection, immune cells, are genetically faulty. And this gives rise, in addition to the lymphedema, to life-threatening infections, and also, because of the blood abnormality, there is a risk of developing lymphedema, of developing leukemia because of the blood abnormality. So it's important to recognize certain forms of lymphedema if they have bone marrow abnormalities associated with them. And this means that lymphedema, which is often just dismissed as a non-fatal condition, is not non-fatal in certain genetic forms where there are other abnormalities like faults with the immune system or with the blood. So the summary of my symposium, what the messages I want to get across to you are that if we identify the gene fault, the genotype, the mutation, for a particular type of primary lymphedema, it first of all permits an accurate diagnosis. There's no doubt then about what that person has. And once you know the gene fault and you know more about the gene, so you can then advise the patient in terms of genetic counselling, likely inheritance, and family planning. The other thing that knowing the gene does is to tell you about the natural history. We can then know and watch patients as they, or children as they grow. We can understand the other abnormalities that may or may not coexist, and we know what happened in the future, like the leukemia, and we can be alert to that phenomenon. The other thing that knowing the gene fault does is it teaches us about the function of that gene. Biologists can then go off and look at cells, look at animals, and study the gene in more detail and try and understand what this gene does in normal physiology. And that's very important because then that might have a role in lots of other diseases where lymphatic malfunction, but not necessarily lymphedema, play a part. And finally, knowing the gene fault informs on the mechanism of the disease, like in Milroy, the small little lymph vessels not absorbing fluid properly, or in lymphedema distichiasis, where the valve is failing, and therefore that's where we need to target if we're going to provide a good treatment. I'd like to really acknowledge the team that I work here at St George's, particularly in what we call the Lymphovascular Research Unit. I like that name because we all know about cardiovascular and the way that that affects the heart and the blood circulation, but it doesn't really generate the right interest in the lymphatic system. And lymphology is more the study of the lymph system. Here I think we have a clinical name, Lymphovascular Medicine. And Professor Sahar Mansour is the Professor of Clinical Genetics. Dr. Pia Ostergaard is in the laboratory, and she's a reader in human genetics, and she is the one that finds the genes. Professor Steve Jeffries, the retired Professor of genetics in the lab. Dr. Gordon is my clinical consultant colleague. Glenn Bryce did most of the phenotyping in the early days and is still an important part of our research program, as is Sylvia, and of course a lot of our collaborators, only a few of whom are mentioned here. And of course we've been blessed in the UK with good funding from the British Heart Foundation, and now we have 5 years funding with the Medical Research Council to allow us to continue with this sort of research work. But we need to encourage many others to get involved in the lymph system if we're going to make really good progress in finding new treatments. This is just an example of the cover of the book that I've got no financial interest in the book at all. I just want to get it out there really and the chapters that tell us about the lymph system, the perils of infection, treatments, what it's like to live with lymphedema, and particularly elements like children with lymphedema, other forms of lymphedema, particularly facial lymphedema and different body sites, and then finally lymphedema worldwide, because it is a global disease, as we were saying earlier. So this is my final slide. This is a young lad who appears in the book. His name is Rafa, and he's been very happy to be named and known as Rafa, and he's called Rafa because his mother liked Rafael Nadal, tennis player. So it was a great fun to be able to take him to Wimbledon to play tennis. And you can see that he's got pink gloves on, and he's got pink gloves on because he's got lymphedema of both hands, and despite that he's still able to hold a tennis racket and beat me. So, and that's when he's 7, so goodness knows what's going to be like in years to come. But it's a great story, and you can read Rafa's story in the book. So thank you very much.
We have some questions.
Okay,
coming
Bill.
in. First question. When do you think there will be a drug treatment for primary lymphedema?
Well, that's a very good question. I think the answer is very soon. I'm very optimistic. The reason I say that is, first of all, many of you will be aware that Professor Stan Roxon from Stanford has already started drug trials in secondary lymphedema and is hoping to extend a particular type of drug for use in primary lymphedema. But I'm also hopeful that the research that's being undertaken, not so much by us in humans, but in biology, trying to understand what the mechanisms are for these diseases, these scientists and biologists will hopefully be able to target the fault, the genetic fault in the tissues of the lymph system, and in time then design targeted treatments for particular conditions. So like the Milroy disease I mentioned, where I think the fault is purely a failure of the little lymph vessels to work properly, I do feel strongly that that can be a potential target for drug treatment in, I won't say the near future, but certainly in the future.
Another question that relates to secondary, asking, will gene testing ever be helpful for secondary lymphedema?
Well, I think eventually it might be. I referred to earlier and said that I feel many forms of secondary lymphedema do have a genetic susceptibility. And if we take just breast cancer-related lymphedema, for example, I think it's looking highly likely that some women, if I say women, 1% of breast cancer affects males, so they get it as well, but in general it's women, that there does appear to be some evidence coming through that there is a genetic predisposition to that. It's not that unusual to hear mother and daughter might have not only the breast cancer but get the lymphedema as well. But I think it's not going to be one single gene like I was talking about with some of the primary lymphedemas. I think there may be a range of genes that might provide a genetic susceptibility. So if we then have a gene panel, we might be able to stratify risk according to whether someone's likely to get lymphedema, and that may be important at the stage where lymph glands are removed or not removed, or chemotherapy is given or not given according to risk. So I think genetic testing may well become part of management of even some of the secondary lymphedemas in the future.
You actually have a gene pool study that you're doing currently.
Well, yes, we've, through identifying a number of genes I think we found about 8 genes here, and others around the world have found other genes. Those genes that are now known, we've put together in a gene panel that is available, and so all one needs is a blood test so that DNA is available, so that we can subject that DNA to the gene panel and see if it comes up with any particular known gene to cause primary lymphedema. If it's a mosaic fault, such as I was talking about with the birthmarks, then in the future it will need a biopsy of the birthmark tissue to undertake gene testing. But the gene panel is now up and running at St George's, and this will be available throughout the UK for anyone who wants to provide a blood sample for DNA testing.
Now tell me, is that available beyond the UK? Let's say someone in India, the United States, is interested.
Yes,
How would they go about?
Well, I'm no geneticist, but as far as I understand, we would just need the DNA. So I don't know how easy it is to send blood samples, but certainly DNA can be sent. And the price of it at the moment, I think, is about £650, which seems a lot. But bearing in mind before that, each individual gene testing might have been £300, £400, £450. So to have a range of genes testing is actually quite good value. But it's still worthwhile being relatively confident that your phenotype fits in to the area covered by that gene panel. Otherwise, you're sort of rather wasting your money. So you do want to be confident that your patient's characteristics sort of fit one of those genes that exists in the gene panel.
So if in fact people are so advised in other countries, they can contact St. George's?
Yes, absolutely. Yes, they can contact us or the contact LE&RN, and then you can send the details on to us. Is probably the easiest way at the moment of answering that question. Yes, and then we can undertake that testing if appropriate.
Excellent. Another question. Why are the new microsurgery operations not more widely available for primary lymphedema?
Well, the trouble with primary lymphedema is that, as I was alluding to, there are often different mechanisms causing the lymphedema. Milroy lymphedema distichiasis cases in point. So, for example, there are a number of operations. The main one probably is the lymphatic venular anastomoses. This is an operation, a super microsurgery operation, where a tiny little lymph vessel is connected to a vein to overcome a downstream blockage, so the lymph can then drain freely away through this join between a small lymph vessel and a vein. But that operation would only work if a lymph vessel that was blocked could be identified. So in Milroy disease, it's a non-starter. So it very much depends on what the fault is as to whether that surgical operation is suitable. So, for example, the other operation that's being used is lymph node transfer, on the principle that one might be able to put a lymph node in and grow lymphatics to undo a block. That's still, I think, more unclear as to how successful that is. But again, the answer's the same. It depends on the mechanism that's causing the lymphedema as to whether that particular operation is suitable or not. So it all depends on the mechanism.
A question here that relates to lipedema. And the question is, does lipedema cause lymphedema? If so, will weight loss help, either or both?
Okay, well, it's good that we've mentioned lipedema, because we also have a research program funded by the Lipedema Foundation in the States, looking at the genetic basis of lipedema. I think it's important to explain that lipedema is basically a swollen legs due fat deposition independent of obesity. It gives rise to disproportionate fat swelling, on the legs, and therefore the name comes from lip meaning fat and edema meaning swelling, whereas lymphedema means lymph fluid largely collecting in the tissue to give rise to swelling. But lipedema does give rise to lymphedema over time. We don't understand why. My hypothesis is that lipedema is not just about fat. There is probably a degree of lymphatic dysfunction responsible or present in lipedema, hence why many of the women who get it, because it seems to be a female disorder, why they then can go on to develop lymphedema. So there's a lot of research work to do with lipedema before we understand what's going on and what might be the best treatment for it in the future. But yes, is my short answer, yes, lipedema can cause lymphedema.
I think perhaps we can close. There's one more of a comment than a question that came in saying, so excited to read the book. Thank you for putting it together and for the work you and your team do for our community.
Well, thank you very much.
I think, Professor Mortimer, which you prefer, professor or doctor? In the United States, we use doctor, but here in the UK, they seem to use professor.
I
since
don't
you
mind.
do teach at the university
I
as well.
don't mind. I respond to anything.
Well, I'll just call you friend at this
Absolutely.
point. Thank you very much for doing this. For our audience out there, having somebody of the stature of Dr. Mortimer to come forward and to provide this information is, to use what they would say here, brilliant.
Well, that's very kind. Thank you very much.
Thanks, Peter.